If you are a primary care clinician, this video is for you. I am Rahul Srivastava from A4 Medicine, and in this video, we're covering NICE guideline NG115 on chronic obstructive pulmonary disease or COPD in adults over 16. This is not a new update, but it remains an essential guideline to understand in UK primary care. COPD is common, progressive, and easy to recognize because symptoms often develop gradually over time. We cannot cover every part of the full guideline today, so this review focuses on the key practical points that help us understand the diagnosis, inhaler choice, exacerbation management, and referral. When to suspect COPD? NICE says to suspect COPD in people over 35 with a risk factor, usually current or previous smoking, who have one or more typical symptoms: exacerbation, exertional breathlessness, chronic cough, regular sputum production, frequent winter bronchitis or wheeze. In primary care, these symptoms are easy to normalize, especially in smokers, but this is exactly where COPD can be missed. A useful bit of physiology here is that COPD usually reflects a mixture of chronic bronchitis and emphysema. Chronic bronchitis means inflamed mucus producing airways. Emphysema means damage to the alveoli, the tiny air sacs where gas exchange takes place. Together, these changes narrow airflow, reduce elastic recoil, trap air in the lungs, and gradually cause worsening breathlessness. The Medical Research Council dyspnea scale helps grade how breathless the patient is in day to day life. And that matters because it helps guide pulmonary rehabilitation and gives prognostic information. Also, remember the red flags: weight loss, chest pain, hemoptysis are not typical simple COPD features and should prompt you to think about other diagnoses, especially lung cancer. One of the commonest primary care question is whether this is COPD, asthma, or an overlap. COPD tends to occur in current or former smokers, usually starts after 35, and causes persistent progressive breathlessness with chronic productive cough. Asthma is often more variable, often starts young, and is more likely to cause night symptoms and day to day fluctuation. In practice, history is often more useful than a single test. Here is the key point that often gets muddled. NICE recommends post-bronchodilator spirometry to confirm COPD, but says routine formal reversibility testing is not needed for most patients. These are not the same things. Post-bronchodilator spirometry asks, does airway obstruction remain after bronchodilator? Testing asks, how much did the number change? NICE says formal reversibility testing can be misleading because results vary between occasions and do not reliably predict long term response to treatment. It becomes useful only when asthma is still genuinely in doubt. And even then, NICE says only a large response really counts. That is more than 400 milliliters improvement in FEV1 after bronchodilators, more than 400 milliliters after a 2 week course of prednisolone 30 milligrams daily, or more than 20% peak flow variability. Uh, Essential baseline investigations. Think of these four basic investigations. First is post bronchodilator spirometry, because this is what confirms persistent airflow obstruction. FEV1 means forced expiratory volume in 1 second, and FVC means forced vital capacity. A simple way to explain it is how much air comes out in the first second compared with the total blown out. If the ratio remains below zero point 0.7 after bronchodilator, that supports COPD. Second, a chest X-ray. This is not to diagnose COPD, but exclude other pathologies such as cancer, fibrosis, or bronchiectasis. Third, a full blood count, looking for anemia, which can worsen breathlessness, or polycythemia, which suggests long-term low oxygen levels. And fourth, BMI, because low body mass index is a poor prognostic marker in COPD. And these are the four basics. If symptoms seem much worse than a spirometry suggests, or if another diagnosis is suspected, NICE points towards additional investigations such as sputum culture, ECG, echocardiogram, CT thorax, TLCO, or alpha 1 antitrypsin testing. TLCO means transfer factor for carbon monoxide, and it helps assess how well gas exchange is happening across the alveoli. Regarding severity and prognostic factors, COPD severity is often staged using FEV1 percent predicted. But NICE is clear that COPD is a heterogeneous condition, so FEV1 alone is not the whole story. Prognosis is also shaped by smoking status, MRC breathlessness scale, exacerbation frequency, hospital admissions, BMI, chronic hypoxia, core pulmonale, multimorbidity, and frailty. Core pulmonale means right heart strain or failure caused by long standing lung disease and increased pressure in the pulmonary circulation. So, in real primary care, do not treat the spirometry number in isolation. A patient with only moderate obstruction on paper may still be high risk if they are frail, frequently exacerbating, or losing weight. Before escalating inhalers, NICE wants the foundations done properly. Smoking cessation is the single most effective intervention in COPD because it slows disease progression more than any inhaler. Record my cues, ask about smoking at every opportunity, and offer support every time. Pulmonary rehabilitation is also key, particularly for people who feel functionally limited, often from MRC grade 3 upwards and after hospitalization. It improves exercise tolerance, symptoms, and quality of life. Vaccination matters too, especially annual influenza and pneumococcal vaccinations. And one point that is easy to miss in busy clinics: do not just prescribe an inhaler because it looks right on paper. NICE says the patient should be trained to use the device and should be able to demonstrate satisfactory technique. The right drug in the wrong device is still poor treatment. Let's review the inhaled therapy pathway. This is where acronyms can lose people. So let's slow down. ASABA is a short-acting beta-2 agonist, a quick reliever that relaxes airway smooth muscles. The classic example is salbutamol, often known as Ventolin. A SAMA is a short-acting muscarinic antagonist, such as ipratropium, often known as Atrovent. NICE starts with a short-acting bronchodilator as needed. If symptoms or exacerbations continue, the next step depends on whether asthmatic features are present. If not, NICE recommends LAMA plus LABA. A LAMA is a long-acting muscarinic antagonist such as tiotropium with brands including Spiriva or Braltus or amaclidinium such as Incruse Alepta. A LABA is a long-acting beta-2 agonist such as salmeterol or formoterol with examples including Ceravent and Oxys. If asthmatic features are present, consider LABA plus ICS. ICS is inhaled corticosteroid, which reduces airway inflammation. Examples include budesonide and beclomethasone. Common combination examples include Symbicort, which contains budesonide and formoterol, and Foster, which contains beclomethasone and formoterol. The physiology behind the split is simple. Bronchodilators open the airway and reduce airway trapping. Steroids are not primarily bronchodilators, they reduce airway inflammation. That is why NICE is more selective which ICS or in COPD than in asthma. Triple therapy means LAMA plus LABA plus ICS together. Before stepping up, NICE advises a clinical review. Has non-pharmacological care been optimized? Are these really COPD exacerbations? And are the daily symptoms really due to COPD rather than obesity, heart failure, anxiety, or another comorbidity? That review matters because triple therapy is not an automatic next step. If the patient is already on LABA plus ICS, offer triple therapy for ongoing symptoms, one severe exacerbation, or two moderate exacerbations in a year. If the patient is on LAMA plus LABA, triple therapy is mainly considered for exacerbation benefit, and symptom only escalation may be tried for 3 months and then reviewed. NICE also reminds us that ICS carries a pneumonia risk, so document the reason for continuing it and review at least annually. Single triple therapy examples include Trelegy and Trimbo. Two later stage treatments are worth remembering. These are both specialist led. First is prophylactic azithromycin may be considered in selected non-smokers with optimized inhaled therapy who still have frequent exacerbations, especially with sputum production. NICE says to check sputum culture, ECG, liver function test, and to think about other causes such as bronchiectasis. Second is LTOT or long term oxygen therapy. This is for carefully selected patients with chronic hypoxemia and is one of the few interventions proven to improve survival in the right group. NICE says assess with arterial blood gases when the patient is stable. It is not simply a treatment for breathlessness and it should not be offered to people who continue to smoke because of fire safety risk. Just terminologies: PaO2 means the partial pressure of oxygen in arterial blood, and SaO2 means oxygen saturation measured by pulse oximetry. These terms matter because they tell us whether the patient may qualify for oxygen assessment. Specialist referral is when diagnosis is uncertain, symptoms are disproportionate to spirometry, disease is severely or rapidly progressive, or when you suspect another important process such as bronchiectasis, pulmonary hypertension, alpha 1 antitrypsin deficiency, or malignancy. Also refer for oxygen assessment, long-term nebulizer assessment, recurrent infection, hemoptysis, bullous disease, lung volume reduction review, or transplant consideration in selected patients. In day-to-day general practice, the important skill is not memorizing every specialist pathway. It is recognizing when the patient is no longer following a straightforward COPD course. An exacerbation is a sustained worsening of symptoms beyond normal day-to-day variation with acute onset and need for treatment change. Mild exacerbations may be managed by increasing reliever inhalers. Moderate exacerbations often need treatment in primary care with steroids or antibiotics. Severe exacerbations need hospital assessment. NICE recommends increasing short-acting bronchodilators and using prednisolone 30 milligrams once daily for 5 days if breathlessness is affecting daily activities. Antibiotics are used when sputum becomes purulent and there is increased volume or thickness. Rescue plan matters because earlier recognition and earlier treatment can reduce admission risk. Uh, Oxygen levels and nebulizer. This is an important practical slide because in real life, oxygen levels and nebulizers often create uncertainty. In stable COPD, if the oxygen saturation on air is 92% or less, NICE says the patient should be assessed for long term oxygen therapy. During an exacerbation, a saturation below 90% is one factor favoring hospital treatment. That is different from 88 to 92% range used when emergency oxygen is being given in an acute COPD exacerbation. So, a saturation of 89 to 90% may sometimes be seen in COPD, but we should not make decision on saturation alone. We need the whole clinical picture: breathlessness, general condition, comorbidity, confusion, whether the patient can cope at home. Also, remember that pulse oximetry can be borderline or inaccurate, especially near decision thresholds. On nebulizer does not nebulizers NICE does say that they are automatically NICE does not say that they are automatically better than inhalers. In stable COPD, handheld inhalers are usually preferred. A nebulizer should be considered only if breathlessness remains distressing or disabling despite maximum inhaler therapy, and it should only be continued if there is clear benefit. During exacerbations, either nebulizers or handheld inhalers can be used. And if the patient is hypercapnic or acidotic, the nebulizers should be driven with compressed air, not oxygen. Do not use oxygen saturation alone to decide management, and do not assume nebulizers are better than inhalers. Exacerbations escalate early if the patient has severe breathlessness, confusion, reduced consciousness, cyanosis, worsening edema, poor general condition, inability to cope at home, low oxygen saturation, rapid deterioration, or significant comorbidity. These are the patients at high risk of respiratory failure and they may need blood gas assessment, more intensive bronchodilator treatment, or non invasive ventilation. An IV means non invasive ventilation, usually mask based ventilatory support, used when the patient is tiring or retaining carbon dioxide. In primary care, the key message is simple: if you think the patient is tipping into unsafe territory, refer sooner than later. The main message key takeaways are these: support suspect COPD clinically in right patient, over 35, smoker or active smoker with typical symptoms. Confirm it with post bronchodilator spirometry. Build the foundations first with smoking cessation, vaccination, pulmonary rehabilitation, and self management. Then use inhalers logically, short acting relief first, LAMA plus LABA when there is no asthmatic features, and LABA plus ICS when there are. Step up to triple therapy carefully with a clear reason and regular review. For exacerbations, use prednisolone 30 milligrams for 5 days when symptoms affect daily life and know when to refer. And always remember, the correct inhaler only works if the patient can use the device properly. Thank you for watching. I am Rahul Srivastava from A4 Medicine, and I hope this review for NICE NG115 has made COPD management feel clearer and more practical for primary care. If you found these useful, please like, subscribe, and share. And for more clinical teaching resources, please visit A4 Medicine. Thank you.